The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Well, hello again. This is your co-host, Dr. Herb Bravo, and joining me is your co-host, Dr. George Rogo from Long Island, New York. Today we have a very special guest, but before I start the introduction, I want to remind all of our listeners about a very special event that we will be attending on February 3rd and 4th at the Royal Sonesta Hotel Galleria in Houston, Texas. This is the Pediatric Management Institute, or PMI, and is put on by our friend Paul and our friend Chip from PCC. Please remember to come, and if you're not coming, go to their website, pmi2023.rsvpify.com. Again, pmi2023.rsvpify.com, and listen to the shows and lectures all online on real time. Now let's get back to introducing someone who we will be sharing time with at the PMI in Houston with Paul and Chip and many other great leaders in pediatrics management, and supergroups. So today we have Susanne Madden, who is the founder and CEO of the Verden Group, a consulting firm founding to help practices navigate through an increasingly complex business of healthcare. She's also a co-founder of an independent practice MSO. She was formerly a practice administrator and billing manager, and she understands the many challenges facing practices today. With an MBA in both management systems and information communication systems, she has applied her formal learning to understanding the principles of knowledge management and how information can be transformed into comprehension at all levels with the right facilitation. Hi, George. Good to see you again.
Hey, Herb. It's Tuesday morning. Once again, we usually elevate great physicians, but we have Susanne Madden, who is a practice management consultant that has done great things for physicians. So she's going to help us to understand her topic of the mindset of the insurance carrier.
Great. Susan, it's great to have you on the show. How are you today?
Thanks for having me on. And I'll obviously be talking about one of my favorite subjects. So thanks for giving me an opportunity to just talk to your audience and be on with you two cool guys.
Great. So we usually start with a different question, which is, why did you become a pediatrician? But since you didn't become a pediatrician, I was looking over your journey, and you have quite a scholarly career. You have a bachelor's degree in economics, then a combined MBA, and then you did a capstone or specialization at MIT. How has the economics degree and your MBA and that MIT degree help doctors succeed?
It's a great question. My educational journey was sort of born out of this need to understand business from a larger perspective than just, focused on healthcare. So at the time, I went back to college as an adult learner. I was raised in Dublin, Ireland, so I had done some college there, but my focus was in marketing, sales, and advertising. Fast forward a couple of years later, I ended up in New York and living in New York, and I, went back in my late 20s to get a business degree and an economics degree. And I was already working in healthcare at that time. So why not go into, healthcare and get, an MHA or something like that? I really wanted to have this wider view of business and then bring that to bear in healthcare. When I had an opportunity to move straight from the degree into an MBA program in Fordham, I took advantage of that and focused on management systems and information and communication systems. So at the time, and that was sort of like early 2000s, I'll date myself. But at the time, obviously there was huge growth in HIT and health information technology. And so doing that combined master's MBA in information and communication systems, I felt really helped allow me to understand the management side of things, the IT side of things, and then obviously having the degree in business and in economics, helped me understand just how it all sort of, fit together from a business perspective. So what I've found over time is, with that sort of level of understanding and comprehension around all of these areas, I'm able to translate things in a way that other folks in healthcare that have really sort of focused myopically or more myopically on healthcare don't have the same sort of vernacular. So by that, I mean, I speak payer and most physicians, speak healthcare. And so in doing so, I've really been able to very handily sort of cross that chasm, if you will. When payers are talking about fee schedules, they're looking at it as economists and bankers, right? They're controlling the dollars, not healthcare. And physicians are always thinking that managed care means actual care, healthcare itself. And so I like to think that, all of that education was combined to, to sort of bring that to bear. The course that I did at MIT was really to understand how to be a sort of a process improvement specialist. And so looking at, the process of business design and how to really, sort of understand throughput and efficiency in services in particular, that was really sort of the reason why I took that course at MIT. And how that has played out is really being able to walk into a practice, look around and sort of see what doesn't fit well together. Where do we need to have, more avenues of flow? What are we doing that's inefficient? How can we actually look at the people that we have and figure out, what is the best way to manage and balance to all of that work, coming in. So that was a fascinating journey too.
Isn't it frustrating for you with that background with the MIT degree when you walk into a doctor's office? Because there's so many inefficiencies that cannot be eliminated because the system doesn't allow it.
That's a great question. To a certain degree, yes. It's not frustration with the physician's offices. It's frustration with how cumbersome our healthcare system is, right? It is deliberately overloaded with process because that's where the profit is made, right? How does an insurance company make its profit? It's, somewhat in the transaction between paid premiums, what is actually sort of coming in, and then what they actually have to pay out, which they refer to as the medical cost ratio, right? Medical expenses are a cost for insurance companies, believe it or not. And so they make margin on that, obviously, on holding that cash. But where they, really make their money is supporting all of that expense that goes into it. So if claims, was a much easier system to follow, if it wasn't so cumbersome, if there wasn't, margins for denials and all of those sorts of things, if we didn't have to call for, referrals and, pre-authorizations and all of that sort of, very administrative heavy, expensive, pieces of process, then the system would flow a lot easier, but there'd be a lot less money to be made by the bankers and the economists and the business people on the other end.
And then I noticed you started your journey as a pediatric office manager.
I sure did. Did.
What lessons did you learn being on the other end, managing a pediatric practice?
I'll tell you, my learning began as a receptionist in a surgeon's office in my very early 20s. So I went from receptionist to medical biller to surgical booker, and then into office management, and ultimately, went into pediatrics. Absolutely, that's where my love of pediatrics is born, and almost exclusively our clients are pediatricians. I'm all about, helping support independence of the little guy, and, pediatricians are the ones that, are the busiest, and earning the least in healthcare. So, the surgeons can take care of themselves. The pediatricians, need all the help that they can get. But I will say to you that having worked all of those different jobs, really, sort of literally climbing the ladder, I'm the American dream story, right? Where I arrive as an immigrant and, start at the bottom of the ladder and work my way up and get an education and own my own business and employ people. But having done all of those jobs, it gave me obviously, complete fluency in all of the aspects of those positions. And the really unfortunate thing is, even in 2023, it's not so different than what it looked like in 1996, right? 1997. Unfortunately, we're still heavy on the phone, heavy on the fax, which is crazy. I mean, it's been shifting, but those sorts of things, still remain today. So, when I sit down with a practice and I'm trying to assess, where are the issues that are most painful for them, sometimes that's in HR, sometimes it's just, how are you actually managing your staff? Looking at, do we have the right people, the right the right folks in the right seats. Do we even have the right seats, right? Sometimes it's the wrong job. And so you can't possibly staff well for it because you're trying to staff the wrong things. So having been a manager, and obviously being the one that would, hire and, be in charge of how, work gets accomplished every day and what our efficiencies look like and how the throughput looks like, it really gives me, true insight into the challenges for both the practice administrators and managers, as well as the physicians and physician owners that are, all trying to work together in this, very administrative heavy structure that we call US healthcare.
I have a question.
And
Why do you think pediatricians are at the bottom of the pay scale?
Well, a couple of reasons for that. A couple of reasons. I think primarily primary care is not valued in the same way as surgical specialties are. And that did not used to be the case. 30 years ago, 40 years ago, primary care and pediatric care was, really considered, in the same way, in the same light. I think as surgical technologies developed, right, as we had med tech evolve over time, the sort of surgical aspects got a lot of attention, got a lot of time from the payers, and also had a lot more clout, right? Most surgeons are attached to hospital systems. Most pediatricians are independent. So when you're, I think what's probably still about 35-40% of pediatric practices are still 2 to 3 physicians, three and less, right? So you've got lots of very small independent practices that are trying to advocate for themselves and advocate up through organizations like the AAP and SOPM. On the surgical side, you have a lot of surgeons that are attached to very powerful hospital systems, and those hospital systems were able to, not just advocate, but certainly have a lot of leverage, with the payers. So over time, and I can say this, definitively, having worked at UnitedHealthcare myself in 2005, 2006, 2007, where it's about moving the dollars around, right? It's not about like, oh, well, we need to sort of, make sure that primary care, is on parity with the surgical specialties. It was a matter of, if this big system got a big chunk of change on a contract renewal, there wasn't, enough to go around, right? And so where are you going to pull it from? Because the insurance companies aren't taking that out of their profit margins. Right. And this is the really concerning thing about healthcare here in the US. We don't have reinvestment in healthcare. What we do is we have a siphoning off of profit into shareholder pockets. Right. And so without that reinvestment, it's taken things like, the Affordable Care Act and, looking at patient-centered medical home models to be able to pull some of those dollars back into quality of care, being able to actually, invest in keeping people well, right? Sickness became a really big business is what I'm trying to say. And with that really big business came a lot of profit, and there's no profit in taking the long view and investing in pediatrics, right? Because those are the healthiest patients we have. There's not a lot of dollars. As I like to say, pediatrics is budget dust for most insurance companies. It accounts for 2 to 3% of their budgets. So pediatricians don't get a lot of love that way. You don't get a lot of attention, and certainly, not a lot of economics flow there because there's not a big return on it for the payers in the short term. They're quarter to quarter, right? They're managing quarter to quarter profitability. Pediatrics is managing the whole person over the long term for a good, 18 to 21 years.
So you touched on many subjects. First of all, we don't have health insurance in America. We have a Ponzi scheme.
Truth.
That there is no, insurance. If you think of insurance, think of a whole life policy where I put money into an account. Part of it insures for my risk. When I was very young, the part that insures for my risk is minimal. Most of it accrues to the account the insurance company invested. When I'm 60, most of the premium goes to insuring my life because I'm at risk of dying. But there's a whole bunch of money that is saved through life that will be mine or my heirs when I die.
Right.
That is not how insurance for healthcare works in America. We rob Peter to pay Paul.
Yeah.
Second of all, many physicians think the insurance health plans are the enemy. The enemy has and always will be the large hospital systems.
Correct.
Because they strong arm the health plans into huge contracts for heavily expensive, burdensome, and sometimes unproven technologies that we all pay for. We pay through taxes, we pay through premiums, and then, as you said, there's no money left to invest in primary care and keeping the population healthy, which in the long run would put hospitals out of business. So not only do they want to fill the beds, take care of cancer, do unnecessary surgeries, do unnecessary CATs, MRIs, and CAT scans at the most expensive manner to improve their margins, they don't want the population to get better because they'd be out of business.
Well,
So
well, here's where I'll bring my economics degree to bear on that. I hear what you're saying. I think part of the problem is we're always talking about who's the enemy, right? As opposed to saying, how do we come together for the collective good? Part of the problem for hospital systems is when you make investments, heavy investments in building out beds, building out infrastructure, building out, equipment, somebody needs to pay for it, right? You need to pay for that, sort of population. So you end up having to sort of feed the monster, right? Once you've made those heavy investments, how do you support those investments? Where do you get the return on investments, right? And that's where, we see these, really sort of, skewed contracts, coming about, and to your point, unnecessary care. But I think that has changed considerably in the last several years, particularly the last, 5 to 10 years, where we have, quality on the table now, right? So, in the late 90s, sure, it was like, dime a dozen, anybody could get an x-ray anytime they wanted, now there, and then sort of there was the advent of, gatekeeper, PCP, type plans that put a lot of heavy burden on primary care physicians to then, sort of, manage the spigot, if you will. But over time, insurance companies have really managed their medical policies and their reimbursement policies to be more focused on paying for the things and actually produce, higher outcomes. And I can say that definitively, on two fronts. One is the work that we've done with patient-centered medical home programs and the NCQA and developing those. I mean, when those first rolled out in 2008, the first iteration of the PCMH program, we were very quick here at the Verden Group and IPMSO to really sort of spearhead that with our clients to say, hey, this is a really good framework. It seems like a lot of work, but you're doing most of this work anyway. Let's quantify it. Let's figure out, how to streamline it and see if we can get better outcomes here. And then, over time, every 3 years or so, the NCQA would, upgrade and update those requirements for PCMH. Over that trajectory, we work very closely with NCQA to sort of be the voice of the pediatrician, within that organization to have things make sense, right? And to be able to do that. And so we sort of, have seen organizations like NCQA, bring that piece in. And then you see payers. Aetna, for example, was a forerunner on that 2008, 2009. They immediately started paying for that. Anybody that could achieve that PCMH program was going to get an extra 3% on their fee schedules. That's a great use of dollars, being reinvested to produce those quality outcomes. On the other,
let me interrupt you there. Is that on a national level that Aetna does that, or is it just on per region?
Yeah, and initially they rolled it out region by region, but they covered most of the country. They sunsetted, I think, in about 2012 to 2014, depending on where it rolled out in the country. So they started, in one section of the country in 2008, 2009, let that run for 3 years, and then added different regions, as they went. So Aetna's goal there was really to invest the dollars to be able to help practices transform relatively quickly, but they weren't willing to continue to pay that forever. Now therein lies the problem, right? So you have investment, so much like the hospitals you were just talking about, they invest and build out all this infrastructure. You have pediatric practices that invest the dollars to become a patient-centered medical home, right? To really have that care coordination piece, to have, plenty of access. You invest in all of these things, and then the payer says, okay, well, we're done now. We were going to support you for, 3 years, and 3 years is up. And so, that extra 3%, sort of goes away. So there are real, issues and real problems with only investing temporarily in these things. But what has happened, I think, with the advent of health information technology really improving over time is we do have the opportunity to run practices much more efficiently than we ever did, right? So we gain efficiencies of scale by being a PCMH. We gain effectiveness of scale, by utilizing all of the technologies and frameworks around us to be able to deliver care in ways that are much more meaningful. But the payers too, in their policies, one of my other companies, the Policy Authority, we monitor policy changes. And so we have seen over time, we've been doing this for at least 15 years, we've seen how those policies have changed, right? So things like medtech, there has to be, proven research. It has to actually have been, out there and effectively studied and have clinical trials and these sorts of things before payers are willing to pay for it. Things like, just sort of tightening up holes, in care, where it's like, is this a necessary procedure? Does this actually garner outcomes? Does it improve outcomes? Does it garner something for our investment in these dollars? So there's been a lot of policy change, over the years too, that have happened that has really sort of helped to right size, if you will, this idea of just, an open-ended checkbook, for large hospital systems, to just sort of do whatever it is that they want to do. But all of that said, there still is huge disparity between the investment in keeping patients well versus, the big business that is illness in this country.
Right.
So you touched on many very interesting points, and I have a couple more questions. One, I love your journey through the medical office, and there's always a debate in management. Does the CEO really need to know how the front desk operates? And you'll find half of the people, like the CEO of he worked for Marriott, but it's Ritz-Carlton. He was obsessive compulsive.
Mm-hmm.
He would fly in without letting people know, go into a room and check if the bed was made properly. He would stop people in the hallway and ask them for their credo and gauge and measure. He had this rule: within 10 steps of a client, you have to greet him. Okay. Other people say that's wasted time for the CEO. But when I go into an office, and I see that the office manager is in the back corner in an office that's closed, and there's a front desk staff that called in sick, and she looks very pretty in her high heels and her nice dress, but is locked in the computer, I know that practice is in trouble, because most practices are not large enough to be able to do that, to have managers that are hiding. What are your thoughts? Should the manager, especially most offices are 3 to 5 in pediatrics. So if one front desk person is missing, there's not a front desk manager that can step in. So what do you think that perfect manager looks like? Somebody that at least has the skills to do the front desk, put a patient back, get a blood pressure, step in for a biller, help the biller fix the problem, or the one that hides in the back and gives orders?
So it really depends on the size of the practice, right? So your perfect staff member, whether it's a manager or front desk person or somebody working in the back, your perfect staff person is somebody that is an all-rounder, right? That can pitch in on the phones, that can help room, patients, etc. So what you always want is involvement, right? So it comes down to engagement. So to your point, right, with Marriott, if you don't know how the front desk runs and you don't know how it works, as a manager, you can't pitch in, number one, but number two, you also can't effectively manage something that you don't understand, right? If you don't know how it's supposed to go, how can you actually, train others to do that and emulate that? So to me, the perfect manager is somebody that is always walking the floor. Absolutely, you're going to need time in your office too. Otherwise, you're not managing, right? Otherwise, you're just a team lead, right? Pitching in and filling holes. You're the float, right? And so unfortunately, practices often look to their manager to be the float, and then physician owners decry the fact that the manager isn't managing and she's not getting this done and he's not doing that. And isn't he the manager and he should be able to do all those things? Well, if you're constantly filling the holes, right, and doing, you can't be managing, right? So I want to just really balance that up, in the context of your question. We have to make sure that if we're hiring somebody to do specific management functions, we give them the appropriate time to manage. We also need to make sure that that manager understands how to manage their staff and is literally, the one that's holding space, if you will, for anything and everything that comes up in a day. So it's a really fine line to walk. What I would really hate to see is when you have a small office and you have the manager tasked with billing, phones, follow up with patients, calling insurance companies, literally doing all of the things, right? And then you have physicians that are basically saying, why isn't he or she able to get all this stuff done? Well, because Sally was away for a week and I'm covering the front desk. And if you're covering the front desk, there is no time for anything else, that's the job, right? It's for somebody's full-time job. Yet we expect managers to be able to cover 2 or 3 full-time jobs and their own, right? And then lambaste them when we don't see them out on the floor all the time, being there every time, a physician walks out of the room and has an issue. So the way I used to do it, back in the late 90s, I would always walk the floor, and I would walk it at irregular times. It's not like 10 a.m., Suzanne's going to be walking the floor, so we all better, have our best game on. I would, set up my day, look at what I needed to do, set up times, that I would, be able to do certain things, then go walk the floor. What do things look like? What does the schedule look like? I mean, literally we were doing, huddles, that early morning huddle that we talk about in PCMH, patient-centered medical home. That's just good practice, right? To get a read on what's the day, so just sort of grab the docs together and say, okay, what do our schedules look like? What do we need to do here? Is anybody overscheduled? And we would just sort of get out in front of it, ahead of time. That's good practice. Then I could go to the back and do what I needed to do, right? And then come back up front again and see how things are running. If I saw that the, waiting room is getting full and rooms are jammed up, then I'm asking questions. Why are we jammed up? Who's running behind? Hey, doc, you're behind by 25 minutes. Did you know? Let's get it moving. We're going to throw this sick patient in here, right? And so you jump in and you just sort of change up a couple of things real fast, get the ship righted again, and then you go back to what you're doing.
Right.
But not everybody has that skill, right? I mean, you have to really be able to, multitask. ADHD people are great at this, right? Because you can take your focus off of something, do that, and then go back to your focus again. But most folks don't operate that way, right? And so I would simply say this, if you've got an all-rounder, if you've got somebody that's really very capable and understands all of the workings of a practice, that's always going to benefit you, because then they can do something like I used to do. They can pitch in a moment's notice, fix things, and then go back to what it is they were doing. But often we're hiring a manager because we want them focused on the business. We want them doing the billing and the accounts payable and this, that, and the other. They're not going to have the fluency for also then picking up the phone and being the super, customer service friendly person. So I often like to say, what are we actually hiring for? What are we looking for in this person? And what are our expectations? Because missed expectations or misaligned expectations are usually at the root of human resource issues. So sorry, very long answer to your question.
No, excellent answer. I love the idea that you mentioned huddle. Maybe George's practice, because it's more organized, has huddles in the morning. I rarely ever find a practice that has huddles at the beginning, not even at the beginning of the week, once a week, let alone every morning. But that is a key to getting some of the troubles out of the way when you have time to breathe.
Absolutely.
And
morning and afternoon. Yeah, you can do it twice a day, all the better. And it takes 5 minutes. It's just a quick, hey, let's all huddle over the schedule. What have we got coming in? Where are we? Who's out? Who's on base for this? We have this problem patient coming in. We know this one's going to be an hour. Okay, somebody's got to get, Dr. Max out of that room after 25 minutes, right? Who's on base for that? Those sorts of things just allow the day to run smoothly. Same way as you would, start your day with a cup of coffee, 5-minute meditation, write your to-do list, right? Then you're good. You're organized for the day. Days you don't get to do that, it all goes to heck pretty quick.
And then you mentioned Jim Collins without mentioning his name, but you said you have to get the right people on the bus on the right seat. And then you didn't say, and get the wrong people off the bus.
Yeah.
And when you're a consultant, that's why you're hated. You walk in and you make an assessment and you go, Dr. Bravo's not a right fit for this population, this practice. That is never going to happen. You can keep hitting your head against the wall, or you can do him a favor and do the practice a favor and ask him to leave.
Yeah. I mean, often what I see is when we have issues in practices, it comes down to one of two things. Either you have somebody that is, and it's usually just one person, that is sort of the source of all pain, right? So if you have conflict in the workplace and things that just aren't going smoothly and, things aren't running well, it often does come down to just one person, right? It's either that, or I find that you just have not hired thoughtfully, right? You have the right people, but all the wrong seats, right? So you have somebody that has a natural affinity for customer service, and they're the ones that are, working with the insurance companies and doing transactional billing, right? Get that person out, to the front. And that's why, I mentioned that to me, the perfect employee is somebody that's well-rounded. So I often suggest to practices, hire MAs. And if you don't have MAs just train people into those roles. And that could touch on a whole other thing here, the whole other conversation. You can't get an MA to save your life in healthcare right now, anywhere in the country. I mean, it's just been, it's been appalling actually to see not only just the lack of medical assistants that are available, but even when you find some that apply to jobs and you set up interviews, they no show, it's just been a debacle. So that's a whole other thing. But my point is this: hire in people and then train them to do all kinds of things within the practice. If somebody's working the front desk, find some time to make sure that they also know how to room patients. How do you call a patient back and put them in a room? How do you get them set up? You don't have to, be medically trained to be able to put somebody in a room, pull the sheet, on the bed, greet them, let them know that the doc is running 10 minutes late and somebody will be with them shortly, right? Anybody can do that. So those sorts of things really help because it allows everybody to be able to pitch in and understand all of the jobs, that need to happen. But I often find that when things aren't running well in practice, I like to talk to each and every staff member that works in the practice, if time allows. Sometimes I'm working with very big practices and you can't interview, 50 people, but we do employee surveys in that case. But when it's a small practice, I'll sit down and say, hey, Sally, so tell me about your day. Tell me about what you like to do. Tell me about what you love about the job, what you hate about the job. Right. And pretty soon you find that, Sally would really shine, at the front desk, but Sally's in the back room. Right. And vice versa. Grumpy Susan is up at the front desk and she actually loves to do transactions. She doesn't want to keep picking up the phone and dealing with people. So sometimes we just need to sort of move the seats around and can keep the same people. And they're much happier because now they're doing stuff that they're naturally gifted towards. And that was part of what I learned about dynamic work design at MIT. Right. Is really, how do you have the right amount of workflow coming in that keeps people really, motivated and happy, not so much that they're constantly overwhelmed, not too little that they're undermotivated, right? So you need the right balance of that, but you also need to have figured out who are the right people to be handling that workflow. You don't want to give somebody that naturally shines working with people the transactional job. It breaks their spirit. It wears them down and they hate their job, right? And if somebody doesn't like their job, that's going to show. So you want to build culture around what it is that people have a natural affinity for.
So your culture is about teamwork, being able to pitch in different areas, even if it's not your area of expertise. And do you ever suggest to your practices that they do the DISC inventory or the Big Five, some sort of assessment of what the strengths are of their employees to see where they fit best?
Yeah, absolutely. And often the practices are looking to me and to my team to do that, right? To say, well, you assess them, you tell us, what is actually, going to work. But I'll say it's more than teamwork, right? It's about individual competency. I find that people really grow and really thrive when you recognize where their skill set lies and you give them the responsibility to meet the top of their game. Right. And so in doing that, when everybody's performing to the top of their game, right, and the top of their game may be learning all of the roles, being able to pitch in everywhere that they can, that in and of itself then creates a much more smoother working team. So I think, in the 90s and early 2000s, we had a lot of focus on, teamwork and how do you build your team. And that to me was about sort of slotting people in together. I say, let everybody be an all-star in their particular role, right? They don't have to be an all-star outshining everybody else, but if everybody can shine in the roles that they're given, then you automatically have an A team, right? And everybody wants to work, collaboratively one with the other. So it's a little bit more than teamwork. It is individual competency and capability and allowing people to do that. So, sometimes I'll hear managers say, oh, my team and they can't do this and they can't do that. And I'm like, well, did you ever turn them loose to do it? Oh, well, we can't trust them to do that. Well, why not? Have you ever tried it? Right. And as soon as you give somebody that trust and that respect to rise to that competency and provide the training for it, right? You don't just say, okay, Sally, have a go at billing, see how you do, and see if they sink or swim. Obviously, you want to be able to provide that training, but give them the opportunity to actually show what they can do. People always rise to that occasion, or they very quickly exit because they're not interested in that. And that just, allows that sort of, getting the person off the bus in a very natural way, because now they can't live up to standard. So they tend to atrophy out of the organization.
Yes. And then you mentioned Aetna. I don't remember when Mark Bertolini was at Aetna, but is the importance of culture and mission drive for organizations. So while Mark was CEO of Aetna, it was a very mission-driven company. it was a health plan, but it's very mission driven. And
Yeah.
George, I think, is reading his book right now about his journey with his son's cancer and also his own accident, which left him paralyzed. And that's where a lot of his real true passion for helping people be well came from. Now, Aetna was bought by CVS, and that passion and that mission is gone from Aetna because the leadership and the mission is gone. So
Yeah.
culture is extremely important, whether it's a huge organization like Aetna or a small practice like Greece Pediatrics in Greece, New York. But yeah, that's very important. Now we're going to move on because there's so many questions that I could sit and talk to you for hours. But you work for UnitedHealthcare, which I call the evil empire. There must be more computers at UnitedHealthcare than there are doctors in America. But I don't know that for a fact. I'm just saying it's so fully automated. What did you do for them, and why would you work for them?
Yeah, it was a very interesting journey for me. So I had managed a pediatric practice. I had left to finish a final semester when I was doing my undergrad. I wanted to sort of finish it up. I ended up doing an undergrad and an MBA in 4.5 years part-time. So that just gives you an idea of sort of how driven I was that way. So I left my job at pediatrics to do a last semester to get the degrees finished up. And on the side, we're still negotiating contracts. It's always a matter of like your last employer becomes your first client, when you go into consulting. And so I had done a particularly, torturous contract with Oxford Health Plans. And they came to me afterwards, a couple months later, and said, hey, G, we would like to gauge your interest in maybe, working for us. You could be a physician advocate within the company. We're really looking to, have folks that understand the physician side of things and really advocate for them, internally, because we're economists and bankers and we don't really get that. And so that might be, really useful for us. And I thought, well, now here's a really great opportunity, right? Let me sort of go within and help be the voice of the physician, internally, so that, I can sort of help to balance things up and right size things. So I accepted the position right as UnitedHealthcare acquired Oxford Health Plans. And you can imagine my horror when I got my papers and it had UnitedHealthcare all over it. I was like, wait a sec, what the heck just happened? And that's a funny story because I had pulled the pediatric practice out of UnitedHealthcare when I couldn't get, the rates that I wanted for that practice, in the 90s and had really had this torturous battle, with UnitedHealthcare. And now all of a sudden they're my employer. So I thought, oh God, how did I land up here? But I'm like, all right, fair enough. Let me roll up my sleeves and let me do, as I intended. And so what actually transpired over the couple of torturous years that I was managing the downstate physician network for UnitedHealthcare was really trying to bring those two companies together, Oxford and United. And you want to talk about culture. Oxford was very engaged with physicians. They had, feet on the street. They had reps that would go into offices, explain policy changes, really work, hand in glove. UnitedHealthcare could not have been more different, right? I mean, UnitedHealthcare invented the 1-800 good luck number. That's all I'm going to say there, right? To your point about automation. It's like, good luck, it's if you get somebody, you're doing well. So, there was this huge cultural clash, and so part of my role as a manager, was trying to bring together a UnitedHealthcare team and an Oxford Healthcare team that was actually supposed to be supporting physicians, in Manhattan, the boroughs, Westchester, and then also just given, my own, history and my own journeys in education, was also then working with the management team in New Jersey and Connecticut and New York to try and foster, how do we get efficiencies of scale, across all of our teams here, because we can all learn together. This is a, big learning process. So ultimately I ended up with credentialing and contracting and provider relations, and then the hospitals, and then the ancillaries, all wrapped, underneath me, because it's a, it's a consequence of competence, right? It's like, the more competent you are, the more, you're going to get. But what I really learned from my time at UnitedHealthcare was this: we are truly dealing with economists. It was about sitting down and it's like, here are the numbers. We need to find $50 million this quarter for our shareholders who's getting a haircut. And that's how it was referred to. Haircut meaning let's cut the rates, right? And so medical policy was used to actually tighten things up. Well, if we bundle this procedure in with that procedure, then we save $10 million there. And so I would, be in, these rooms, with the executives, myself being an executive, saying this is ridiculous. Like, what do you do? What are you doing with this? What are the likely consequences of this? Particularly at one point, it was about pediatrics and primary care, right? And about sort of, cutting some dollars there. And I'm like, why would we do that? That is, in fact, what keeps costs down 5 years from now, 10 years from now, 50 years from now. And that's where I learned it's a quarter to quarter cycle, right? It's not about that. So there's only so much heavy lifting you can do. I like to say that I felt like I got off the elevator on the 14th floor in the morning. Somebody doused me with gasoline, set me on fire, and I ran around trying to put myself out for the rest of the day. That was what it was, my experience, there. But I was to blame for that, right? Because I wanted to mix it up with everybody and, really sort of advocate for physicians. And, it was just a total pain in the ass, to those folks, at the insurance company. So, but there's only so long you can do that. So at that point, I decided to exit UnitedHealthcare in early 2007 and set up the Verden group as a way to be able to sort of equalize the playing field, level the playing field a bit, right? If I could take what I know now about all of this other stuff that I'd done and apply that to small independent practice and give small independent practices a fighting chance against the big behemoths, then that might just sort of help to level things out a little bit. And that's why I got involved with patient-centered medical home and quality care and contract negotiations and all of these pieces, because there just wasn't any visibility in it. Physicians would decry the fact that, oh my gosh, like, don't they, the insurance companies understand, healthcare? Aren't they managing healthcare? And I'm like, they're not managing healthcare, they're managing profit margins. That's what they're managing. And once you begin to understand that, then it's an entirely different conversation that you're having.
Now, can physicians really negotiate contracts? My favorite question.
Yeah, and it's a very open-ended question. Some physicians can. Some physicians can with the help of a consultant. Other physicians can't at all because there just isn't any clout or leverage. So I would start by saying, what do you need to be able to have a successful negotiation with an insurance company? Well, you need to have something that somebody else doesn't have, right? You need to be delivering something, whether that's, high quality, valuable outcomes, right, to a payer, or be in an area where there isn't very many of you, right? So for example, it's really easy for me to get reasonable rates for, say, a pediatric specialist, right? A pediatric thoracic surgeon, easy to get, right? General peds in an area like Manhattan, forget it. You sign up with an IPA or you're bust, right? There's just no way any insurance company is paying you more because they don't have to, because if you exit their network, if you don't like the rates, you don't have to participate. And if you don't participate in an area where there's high volume, right? High demand, but also high access, they don't care whether you come or go, right? So we have to create, points of leverage. What do you have to offer an insurance company that is worth them paying more for? And that's, usually where I start when a practice approaches me and says, hey, we want to hire you to negotiate a contract for us. I'm like, what have you got? If you don't have anything, there's nothing to talk about. I'm not going to waste your money and my time, and certainly not going to sort of, diminish my ability to negotiate with insurance companies. Because if I'm just bringing any old practice, to a payer, they're going to be like, we don't have time for this. Why are you bringing us this, Susanne? So they know, the payers know if I knock on their door, it's because I've got a worthwhile practice that has something to offer, and we've got something to talk about. We've got somewhere to go with it, right? Like a clinically integrated network where there's a bunch of practices that are all coming together for purposes of improving, quality of care. Now they're interested. Tell me more. We want to understand that. How can we support that? Because there's a benefit to them, right? It's worth paying more for. But if I say, hey, I've got this, 3-doc pediatric practice with high volume, seeing a bunch of your members, they're like, and who cares? So you really have to, have something different to bring to the table, or something of value to bring to the table to get that off the ground. Conversely, though, I say to every physician, if you don't ask, you can't receive. So you might as well ask. The worst that can happen is they say no. All right. But I would also say, don't play chicken. Don't be like, well, if you don't pay me, better rates, I'm gonna walk. Because if there's plenty of pediatricians or physicians in your network, they'll be like, there's the door. And then what are you gonna do? Right. So let it be more collegial. Let it be, a collaboration, right? And you'll get, more bees with honey, so to speak. If you go to a payer and say, hey, we'd like to work with you, we'd like to earn more, What programs do you have? What can we do together? How can we actually improve care? All we're looking for is a share in that savings, right? All we're looking for is that we can actually have some finance to do better work. And that, facilitates a much better dialogue, right? Than just pay me more. Why should we pay you more? Because I want you to, because your rates suck. Okay, well, that's just really not an argument that's going to go anywhere, right? So you have to have value.
Most physicians think that they do a good job, and they probably do. Most pediatricians, most of them are NCQ certified. Most of them have access. Most of them have good quality metrics and so forth. I think in a physician's head, they expect the insurance carrier to just increase your rates because you're a nice guy, Dr. Bravo, and you're doing a great job. But so are another 15 other people. I remember my early days of negotiations with you. We negotiated some really horrible contract, and they gave us a 20% increase right away. And then he moved some. This was before I met you. The guy moved some monies from the 99213s to 4s to the oh, this up, we'll drop this. Is this good? It sounded good at the out of the gate, but then I realized it was not that good. So then I told them what I think we should do, and they accepted it. It was pretty easy. And I said, so why didn't you just do this from the beginning? He says, why should we? We never asked.
That's right. That's right. Why would they pay you more?
Why should we pay you more?
Yep.
Yeah,
Yep.
so that
Well, and that's the other thing too. They're not going to negotiate against themselves, right? So if you'll accept a 10% or a 2% increase, why would they offer you 10%, right? So it's always that back and forth. So once you get going in a negotiation too, the first thing they're going to say is, well, what are you looking for?
Right.
And so you want to present something reasonable. If it's reasonable, you have a chance. If it's like, we need a 30% increase, you're like, there's the door. That's ridiculous. We're not even entertaining it. They're not even going to model those numbers out, right? So the way it works is, you ask for an increase. If they say, well, put together a formal presentation or a formal proposal on what you're looking for, you want to run the numbers. You want to see, where are the rates now? Where is it that you actually have pain points, right? Make a case for it. Are they, paying, is a particular payer you're talking to, paying a couple of percentage points less on preventive care, for example, than the majority of the rest of your payers? Well, that's a good argument to make, right? You're basically saying you're not paying market rates. I can get, 3 or 4% higher in aggregate with my other payers. So I would like to see those particular, rates increase. And, so do your comparative analysis. And it's not just in aggregate, like if you blend everything together, you might say, getting about 100% of Medicare. In some cases, we wish, right? I mean, in our locality here in New York, base rates, street rates, as we call them, are about 65% of Medicare, which new doctors coming out are just, horrified to even begin to comprehend that commercial insurance pays far less than Medicare does itself. Anyway, I digress. So you're going to be asked to put together a proposal. So you don't want to blend everything together because you may be getting paid relatively well on a couple of high volume codes. And that's going to make it seem like your percentage is higher than what it is. Hone in on those buckets, right? What are you doing in preventive visits? What are you doing in sick visits? What do your vaccine admin, fees look like? And then product is a whole other story. Vaccine product is a whole other story. That's really non-negotiable. Those are pegged to, average wholesale cost or average wholesale price. And you get a certain, percentage around there. But hone in on your services, figure out where your pain points are. Make the case. It shows the payer that you've done your homework, that you know what you're talking about, you know what you're looking for, and then ask for something reasonable. And by reasonable, I'm saying, within that sort of, 10%, you might say, look, can you come up 10%? They'll come back and say, we'll give you 1%, right? So why are they doing that? They're trying to lowball you, right? To see how low will you go. Fight your case. You're not going to get to 10% out of the gate. That just doesn't happen anymore. The margins are very, very thin, but you may be able to land at 3 or 4%. And, the biggest tip that I like to, give practices is, ask for the rates that you want. And once they're locked in, then ask for escalators year over year. So in other words, arrive at the point that you want and then say, well, we'll sign a 3-year contract on that. But in year 2 and in year 3, we expect an increase. And it's usually very minor, could just be 1% or 2%. But at the end of that 3-year term, you're a couple of percentage points ahead than if you had no escalators, and now you're in a renegotiation, right? So over time, you get to move your rates up. I mean, Doc, as Dr. Ragu, you and I, have obviously been doing contract negotiations together for at least 10 years, I think probably 15 years at this point. And, and your rates are excellent because of that, cycle, right? So every 3 years being able to move that up. You've done at least 4 or 5 rounds of negotiations, since we've been together. And that helps to improve, obviously, where your rates sit. Somebody, setting up their practice for the first time and looking at your rates, of course, you don't share them. But if they were to look at your rates, are going to say, well, I want to get paid the same thing. Well, you can't. That's a 15-year cycle, that you've been through to really build that up, build up the value, layer in patient-centered medical home, open an urgent care, do all of the things in collaboration with payers, versus somebody that's like, I'm hanging out my shingle. I want to get paid, the same as this guy. They haven't earned it, right? You've earned it. That's the difference.
So you said a couple of things. I'll disagree with George. I think George is one of the rarities of physicians who understands data and clinical care.
Yeah.
Most physicians don't want to understand data, don't want to understand how their billing department works. They want to go in and see patients and then look at their bank account at the end of the month.
Yep.
And they have no idea of how much money they're leaving on the table or if they're doing a really great job. And they have no idea if they're doing quality care or they're just doing the same thing that they were trained to do 20 years ago when they're in residency. But the idea of sitting down and looking at a spreadsheet and a dashboard to see where you really are, the answer usually is, I run a tight ship. I graduated from Georgetown.
Yeah.
So yeah, that was 20 years ago. You know what? There was no iPhone, and this little iWatch I'm wearing here didn't exist when you graduated from Georgetown.
That's right.
Neither did laparoscopic surgery or the Da Vinci robot or the electric car. Times have changed. It's amazing. So I'll push back, but to your point, you're absolutely right. When you sit down with these people are used to dealing in spreadsheets, numbers, not people. And if you don't come with the numbers and that comparison, even for a small practice, if you can show them a spreadsheet where here's my fee schedule from PPO 1, here's my fee schedule from PPO 2, here's my fee schedule from PPO 3, and you're 10% below all of them.
Mhm.
Explain to me how I'm supposed to not be offended by that.
Well, we have to take the emotion out of it too, right? So, I've had these torturous conversations with payers where they're like, well, doc, I'm not trying to offend you. And they don't even understand what you're talking about. And here's why. You're talking to an employee of a very large company that has healthy benefits, a pension, shares in the company, all of that sort of stuff, sitting across the table from the guy or gal that is, an independent business owner trying to make payroll, every couple of weeks, right? And so the two don't meet. This person has no frame of reference that the dollars that are actually being brought in, that I'm representing for this company, giving you, in fact, is your bread and butter, right? In fact, is your payroll, your grocery money, your take home, your mortgage money, because they've got a job that pays them a salary and this is just what they do, right? So I always like to sort of bring the fundamental of the human condition to bear here, which is to say, who am I talking to and what's their frame of reference? And that's when we started out at the beginning of our show here, just with this idea of, I speak payer, right? I'm trying to bridge that chasm so that I can say to, a physician, it's not personal. They have absolutely no idea. That person does not know what it's like to build a business and to be actually earning that money, by each patient that they're seeing, all right? They signed on, they get a salary, whether they work 8 hours a day, 6 hours a day, 20 hours a day, right? So we have to sort of frame it in terms of what we're asking for. And when we ask for something very dispassionately, and it's very much done by the numbers, we've got a strong case to make. So if I'm talking to a numbers person, I'm putting numbers in front of them because that's all they understand. They don't care about the rest. They don't know about the rest. They don't even want to know about the rest, right? And
Right.
So we have to do it, by the numbers and make the case that way. It's only when it becomes personal. So you had touched on Aetna's, old CEO, his story. It's only when it becomes personal, when your child is sick or when you're sick and you have to go into the healthcare system and you're working with physicians and you're working with hospital systems for your life, basically, to save your life. then you really get it. Then you really begin to understand what all of this is about. But that's the exception, right? And so we have to speak payer if we want to be able to deal in that business world. And unfortunately, every physician that participates in insurance does deal in that world. And so they need some fluency in it.
I always try to make it personal somehow. A couple of things happen in my time. The guitar is behind me. Why are they there? Many times I'll find a guitar player that's on the other side. Start talking guitar. It's personal. We've had cases where the negotiator came to the office as a patient, came with the kids to our office with their children. I've had one contract where the guy lived around the corner from us. It became personal. Once it becomes personal, it's a little bit easier.
It is, because then you're building relationship. And that's why I say, try and go the collaboration tack with payers. If you're like, hey, we want to work together with you, what can we do to improve value? What can we do collectively together? Now you're building relationship, right? As opposed to, you're the bad payer and I want you to do this for me. And if you don't, I'm going to walk. They're just like, yes, please do, because this is annoying and I need to get on with my day, So, you need to
so I'm going to summarize the key points in negotiation. Understand who's across the table.
Yes.
Bring data, not ego.
Correct.
Okay. And have at least 1,000, what is it, lives that you're managing, or attributed lives, so it's worth their time.
Well, you're not even going to get an audience with them unless you have a certain volume, right? So if you're charging 100,000 a year, to a payer, and you approach the payer looking for rates, you're going to be like, who are you? What? It's like, it's not even on their radar, right? So some people ask me, what's the magic number? Well, it depends on the region that you're in. If you're in Manhattan, you need to really be taking care of a lot of patients, with a particular payer in order to, merit their attention. And even then they still may not care, because if you exit, there's always, plenty more that can absorb. So, so there isn't that magic number. There is basically the value proposition, as I call it, right? So you want to be looking at, what is the work that you're doing? Who are you doing it for? You may find that within that patient population, if maybe you're doing 250,000, but there's, a really big law firm in there that's self-funded. There's, the neighborhood, factory is in there or whatever. Now you've got some clout. Now you get to go to the payer and say, hey, we take care of these families on these, two really important clients of yours, right? Because this is the thing, customer is king for an insurance company. Physicians aren't the customer. You're the vendor. That's the hard part. Yeah.
We're the expense.
Exactly. So if it, so you want to know, who are the employers for your patients too. If you're really going to, mix it up with an insurance company and come out as strong as you can, it's always really helpful to know that too, right? Because to George's point, now you're creating relationship too, because you might ask that patient to advocate. If it's somebody that owns a large legal firm, to go to UnitedHealthcare and say, hey, you can't lose this practice out of your network. I hear you're negotiating. You need to make that happen, right? The insurance company is going to want to please their client if they can, right? If you're asking for something that is, beyond the realm of possibility, then you're never going to meet, so you also have to, as step 4, you also have to be reasonable. You have to come at them with something reasonable in order to get it. Same as you would with anybody.
Yeah. I think physicians have a little bit of an advantage because we do have a relationship with our families, right? So if you recall back in the day, Suzanne, when we were dealing with some company and we did the Attack of the Clones project, where the representative just stonewalled, no. You had a good amount of volume. So what do? You reach out to your relationships and have people, we wrote an email to all the patients that had this particular company and says, write me a little story of one thing that somebody at our office did for you on a holiday, on a Sunday, on an evening or something that was relevant and medically life-saving or saved money. And you start bombarding these people with, stories, personal stories. You diagnose a leukemic, you diagnose a diabetic, you save somebody from emergency and whatever, and you have a good number, they listen to that stuff.
What you've done is create value, right? You're showing the value of the services that you're delivering and the care that you're delivering. So, but I will tell you though, Doc, you are it's not for the faint-hearted. You've always been ready to bring, the shield and the sword, at all times. But for most, that's just sort of beyond the realm of what you even want to do. So, to Herb's point, you can sort of start with these, 4 steps. Know who you're talking to, bring your data, create your value proposition, be reasonable. That gets it going. If you really, end up in, fighting hard for things, then they should call you, Dr. Ragu, because you'll be able to help them with that.
So we're going to move on a little bit because you mentioned margins on buying vaccines. And I know you're also the leader of a group purchasing organization, or MSO.
That's right.
What's the case for a group purchasing organization? How does it work, and why should every pediatrician look at one?
Yeah. So we created independent practice MSO. The MSO stands for Management Service Organization. But rather than us, actively manage practices, what we're doing is sort of, having a la carte menu of things to help you manage your practice better, right? So we do a lot of pediatric practice startups at the Verden Group. And what I was finding, this is going back probably 6 or 7 years ago, was that, every time we were doing a startup, I'm looking for the best prices for them. How do we keep costs down? And all of this work is being done. And finally, one day the light bulb goes off, where it's like, hey, if we put this under a buying group, right, then obviously we can, gain efficiencies of scale, but also, have the clout to be able to elicit lower prices, from companies like McKesson, and be able to get, higher rebates for vaccines, because that's where the money is on vaccines. A lot of physicians, unfortunately, think that there are different price points around vaccines. There isn't. It's federally regulated. Your prices are your prices. Where you get to sort of make some money back on that is in your rebate. So going with a purchasing organization is really important because that returns some of that money back to you. But it's as equally important to find the best purchasing organization that you can, so you can get the highest rebate back. So we've seen everything from, 1% of that rebate goes back to the physicians, right? And the rebates are usually about 3%, that the group purchasing organization is getting back from the vaccine manufacturers, right? And so 1% of 3% isn't a whole hill of beans, right? And so we wanted to make sure that we could offer almost the full, Monty back. Now, we're not the purchasing organization ourselves. I'm not handling that rebate back. What we did is contract with one of the largest vaccine, GPOs, Main Street, and said, hey, give us the highest rebate back possible. You keep the lowest margin because we'll bring you that volume, right? We want to do something, different in industry here that really allows nearly all of that rebate to flow back to the folks actually buying and purchasing those vaccines. So we did that with Main Street. McKesson, as we add, every single time we add a practice to independent practice MSO, the rates roll back, right? So it's not just that we have the best rates, the lowest prices for most pediatric medical supplies, but we also squeeze them. Every time we add, we're like, and now we have even more volume. Can you tweak those numbers a little lower, right? So it's like, was it Walmart's rollback, whatever that little happy
Yes.
face is? We were like, we like that idea. Let's bring that idea to bear, in our relationships. And then we have all of these other vendors. We have payment pros that offer the, lowest transaction rates in credit card processing. That saves thousands of dollars a year for practices. I mean, literally thousands. If you go with a bank, they're charging you, $30 a month. They're charging you $3% a transaction. I mean, there's all kinds of cost in that, right? So we looked at all these things and said, how do we scrape out all of this cost? Because in pediatrics, with the volume, that goes through any pediatric practice, these are cumulative savings that really add up, year over year. So that was sort of the premise for that. And when I really started to understand how all of this worked, then we were able to elicit sort of the best deals that we can, for our clients. And we constantly review this. We don't take a piece of this, right? We're not getting a piece of the vaccine rebate. Our goal is, how do we get that back in the hands of our independent physicians, right? And so, how do we even make money on that? We charge a small, membership fee annually for physicians so that we can pass all of that back. But another reason for wanting to do that is I don't ever want to be stuck with a vendor because they're giving me a piece of the pie, right? We don't want that. We want to always stay very fleet of foot and say, hey, this guy has a better deal. Can you match it? No? Okay, then we're going over here with this guy, right? But if I'm relying on some cash flow coming in from them to keep my business going, then I'm kind of stuck in that relationship, aren't I? So we always wanted, myself and Ken Fenchel, who's our other partner, Ken and I founded IPMSO 2016. We always wanted to have that, ability to, come and go as we need to. We're out there scanning for the best prices, the best relationships, the highest quality services. And so we've built up a lot of relationships, with our partners. And then we have, developed that too now to offer what we call remote biller, which is a billing company, but we manage the relationship and you have dedicated people to you as if that's your biller, but they're sitting somewhere else. They're sitting in Utah, as a matter of fact, right? So that you have that relationship. It goes back to relationships again, Dr. Raghu, right? It's always about the relationships. Can you build a relationship, with that person and have that dedicated person, as opposed to most billing companies where it's just like, you send out the claim, it goes in a black box. It's not even built out of your system. You don't know how you're doing. You have to try and understand numbers. You're always chasing them for reports. Everything gets built out of your system. You have that relationship with your designated biller, and it keeps things, very, very transparent. And then we also now do credentialing. We're building up credentialing into IPMSO as well. Again, to keep costs as low as possible, but with the highest possible, most effective outcomes for our clients.
So it's interesting that you touch on billers, because there's many quote unquote billing companies out there.
Yes.
That don't even provide the physicians with a basic KPI of this is what we're doing for you. And they're charging 5.5%, some 7%.
Actually,
And
7
That's right.
most are 5.5% now, but say 7%, and the physicians accept it as it's okay. And I'm like, it's okay, then you're going to pay me to create your dashboard and tell you what the KPIs are. I mean, that should come with your billing service. That's why you're paying them.
That's exactly right.
Oh, they're doing a good job for them. How do you know?
How do you know? Yeah, so that's always it. It's like,
how do you know? How do you know? I mean, an insurance company doesn't pay a CPT code. You're getting zero reimbursement from them. Are they calling you and letting you know that? I don't know. I don't know how they would know that. Well, that's their job to know.
Here's the biggest issue that we found with billing companies. When we first, decided to do this, we thought, okay, we'll build an in-house billing team. My thought on that was, well, we could do that, but are we going to be able to deliver, the best knowledge base? Yeah, and can we scale up, for our clients? Rather, let me look at finding sort of the best billing companies that myself and Ken could find, right? And build relationship with them, help educate them what our pediatric clients need. And it's mainly pediatricians. We certainly do have other specialties in there, but that's always our focus, right? And part of the reason why I wanted to be so laser focused on this is exactly to your point. In pediatrics, you have a lot of very small bills. If you have an insurance or a billing company that is billing out, $1 million surgeries and $9, hearing and vision screenings, guess where they're putting their effort if something gets denied? They're not going after the $9. They're writing that off. They couldn't care less about the $9. But $9 times 1,000 in a pediatric office over the course of a quarter is a whole hill of beans to that pediatric office, right? So we really have gone to great pains to, to build out and work with our billing partner to help them understand, why these things are important and how to do them effectively and well. Now, of course, it takes time to build these things up, right? Month over month, it gets better and better and better. And ultimately, it will be at my standard of my goal and my dream of what this, needs to look like. But we're getting very close and have some great partners in there. But absolutely, anybody signing up for a billing company, your questions need to be, how do you manage denials? How do I see my data? How do I know that you're doing a good job for me, right? And so the other piece that we wanted to make sure was everything gets built out of your system so that you can run a report. You can see in real time how things are trending. You can see if your claims are posted out. You can see what's outstanding. I don't ever want any of our clients relying on a billing company to provide a report to them, because by the time you get that report, it could be 4 months, 5 months, 6 months later, where you see that your collection rate is, tanked, and you have a whole bunch of, patient balances outstanding that you're not going to be able to collect on because it's gone 6 months. and now you're toast, right? That can put a practice out of business. So we were really very, dogmatically pursuant about, quality in billing. And there are just thousands of billing companies out there, and most of them awful. And same with credentialing. We tried to do something similar in credentialing. And so many credentialing companies, outsource credentialing, or they're much more interested in how many applications can they get out the door rather than how many applications are actually correct and will pass muster the first time around at the credentialing committee on the payer side. So we've pulled that back in-house, and now we're actively building that up because we are so focused on outcomes. I don't care how fast you get an application out the door. I care that you get it out quickly and correctly so that we don't have any delays, on the back end. And so there's a big difference, when you come from a practice and an independent practice environment like I have, what's important to those practices, right? When you're a big billing company where it's like, hey, we could make lots of money, out there doing billing for doctors and charge them 5.5%, they've no idea what the actual impact is and what it means to, to work with that revenue cycle.
That's right. And so you also do, you help practice establish the medical home, right?
We do. And in fact, my old partner, Amanda Ciadella, is now sole owner of Patient-Centered Solutions. We're still very actively connected and engaged with one another, but it was a wonderful opportunity for her to go solo on that and for me to put my focus into IPMSO. So Patient-Centered Solutions is still actively helping practices achieve patient-centered medical home status under NCQA's program. And I couldn't recommend Amanda highly enough. She's, the company's still on our website. We're still, as I say, very actively engaged and pass clients back and forth. So you can still, you can find that solution on theverdengroup.com as well.
And then, do you think every physician who is leading a practice needs an MBA?
I don't think you need an MBA to lead a practice. I think you do yourself a great service if you're looking to build up a practice over time and grow a practice and have, more locations and do things like, urgent care and whatever. It absolutely will pay you back in spades, right? The dividends on that are huge because now you really understand how to run a business. You understand how to build business. You understand strategy. You're able to speak payer. All right. You can do all of these things with fluency that you don't have when you have a medical degree. It's sort of like saying, hey, Suzanne, we're going to train you up in a business degree, and now you're, supposed to go over there and, sew fashion, right? It's like, I don't know how to sew. I don't know how to cut cloth, right? So it's the same thing, with physicians. You're trained in healthcare, not in business. So I would say if you're going to build up a sizable practice or looking to do that and grow over time, then an MBA absolutely, helps you with that. And of course, Dr. Ragu is our poster boy for that. But here's the thing, you don't need to go all the way through attaining a degree to get a lot of business fluency. There's all kinds of wonderful courses out there. Paul Vanchier's Pediatric Management Institute and his annual conference is an absolutely wonderful way to engage in that. A lot of EMR vendors have some great users conferences. PCC up in Vermont, their users conference is fantastic. It's as much about management and business as it is about utilizing their software, right? So there's all kinds of wonderful resources out there. And of course, SOPM through the AAP is a great way to just sort of tap into groupthink, right? And learn a lot from your colleagues in pediatrics. But anything and everything that you can do as a practice owner to learn about the business of actually running that practice is going to, really return dividends to you. Yes, you can hire, a practice manager who really understands, things to do that for you. But the minute they walk out the door, where are you? And so I like to say to the practices where we do pediatric practice startups, I want to educate that client as we go. I'm like, you could turn this over to me. We could get all this set up for you and then say, ta-da, you're opening your doors on such and such a date, but that's not going to help you. Instead, we're going to have calls week after week, right, to go through everything that needs to be done so that either you're doing it or the things that we're doing for you, we're explaining what we're doing, why we're doing it, and you're making decisions about, how we're going to get that accomplished for you, because that's how people learn. I want practices when they open their doors to say, I got here, I did it, and I understand everything that's going on in these walls, right? I understand how all of this is put together because I was central to putting it all together myself, right? Because that's how you build on that. And that's what will keep independent practices alive. That's what will keep it sustainable, is growing that knowledge base, right? And that's really important to all of us.
So when is the PMI this year and where?
February 1st. Yeah. So
in
he's
Houston?
it's in Houston. And of course, Paulie's conference, it sells out 50% every time we do a conference, right? So by February 4th, when we're wrapping it up, 50% of the attendees will have already signed up for the following year. So he's already sold out for the in-person, but I think you can still do virtual. I don't think there's a limit on attending these courses virtually. So I would absolutely encourage anybody listening to this podcast to go to Pediatric Management Institute, look at the annual conference, sign up for those virtual courses and classes. I don't think that you have to participate in real time. I think they may be recorded and then you can tap into them anytime. So even if you're attending, it may be worth your while to sign up virtually as well, so that you can tap into that material, over and over throughout the course of the year. And of course, I'm privileged to be a speaker, at that conference as well. So those that are going, I look forward to seeing you guys out there. We'll have a pre-conference day on supergroups and the benefit, of being with a supergroup, whether that's a clinically integrated network, an IPA, a large conglomeration of like-minded people, et cetera. And then doing a wonderful talk on, selling your practice. Do you sell? Do you walk away? How do you do this? So so it should be some good times, out in Houston.
And when and where is the PCC user conference?
That's in July. That's usually in July and usually held in Burlington. Every couple of years they take it on the road, of course, with the weirdness of COVID, who knows where it's going to be this year. They may just keep it in Burlington. They had it in Burlington last year, so I'm not sure what they're doing this year. And, if you're a PCC client, then absolutely you can go to that users conference, but I believe that they also make it available if they're not fully sold out, with their own clients attending, they may be open to having, other people do that. And then just one other footnote, if you can't make it to the Pediatric Management Institute conference, Paulie actually has an entire CPOE, Certified Practice Administrator certification available, online. And that is just chock full of all kinds of courses and classes that you can take and learn about various, areas and aspects of your practice. So that you can do anytime. And that is a very rigorous program that I know a number of physicians have actually gone through and achieved and really appreciated, having the opportunity to tap into that knowledge.
That's very good. Herb, you're going to be at the conference also, right?
Yes, we'll be there.
We'll be there. I'll be there also. I'm going to be doing it at the super groups. I'm going to be on one of the panels talking
Excellent.
about.
Great. Are you guys going to podcast from there? Maybe we should podcast from there too.
Yeah, we have two already on board for that. And we're really looking forward to being there. The one thing that you kind of touched upon, but I'd like to expand and then wrap it up, is I think one of the most important things, two questions for you really. One is, you mentioned doing all these other things, which are great, PMI, PCC, even just talking to you, listening to our podcast. But do you ever go outside of industry to other industries to see how they're innovating and how they're doing things differently to try to bring that into our business?
All the time. And that's, very specifically why I didn't go the, healthcare master's route, was to be able to have that visibility, outside. The MIT course that I did, around dynamic work design had absolutely nothing to do with healthcare and yet everything to do with healthcare, right? It was about how do you sort of, apply these things. Most of my reading, comes from things like, Harvard Business Review, right? It's like, what is actually happening out there in the wider world of business, particularly around efficiencies. I mean, I consider myself an efficiency and process expert, right? So to me, where do those things sit? Often that sits in manufacturing, to be honest. It's it has, it's sort of almost irrelevant to healthcare. But every time we look at those sorts of efficiencies, what are we doing with process steps, in general, in other industries where there's high volume, high throughput, lots of variables, involved in it. That's all relevant to healthcare. I mean, but I would say the one thing that makes healthcare really unique is that on any given day, anything can come through your doors, right? It's a highly variable, dynamic environment. And as such, unlike a factory where you're just building widgets, where you have very low variation, right, and a lot of, consistency in it, being in a very dynamic environment, we need to also be looking at other dynamic areas like the hospitality industry, right? Airlines, various things like that. What are the technologies they're using? So to me, the fact that I can book a flight at 2 a.m. in the morning, I should be able to schedule a doctor's appointment at 2 a.m. in the morning. If I'm up and then it's like, oh gosh, I have to do that. I got to get my son's physical in, I want to be able to do that. If I've got to call a doctor's office and be on hold for 15 minutes or 20 minutes to book an appointment, I'm not going to that practice anymore. Okay. Because
that really is dog poop. I mean, that's really dog poop. But when we're in Houston, remind me to tell you the story about, about that it is a fascinating story. But I don't want to say it in
the online appointments. I've been talking about this for 10 years. All right. And I'm calling out PCC and Office Practicum to do this. It's very easy. It's very easy. I think they don't want to.
The doctors don't want it.
No. The EHRs don't want to do it.
No, George, it's a doctors.
It's a little bit of both, right? It's a little bit of both. So anytime I suggest to physicians, and I'm going to have to, say this out loud and on the air, it is generational. Okay. My millennials are like, what do you mean I gotta have people that take appointments over the phone? They don't understand it. Okay. They're like, we'll present some software to them or whatever. And they're like, okay, so where's the online scheduling and how do I communicate with them, in a secure environment? That's what they want. They want to use tech. Yeah. They, phones and fax. They're like, I don't know what a fax is. I mean, I literally had somebody say, I'm not sure what a fax is the other day to me. I realized how old I am.
What's a patient portal? What do I need a patient portal?
That's right.
I can't have the business. So we'll talk about this. This is another conversation, or we can talk
another podcast.
We can talk about this in Houston. What was the other thing I wanted to mention? We got side rail here.
What does your business of medicine look like?
Well, no, hold on. So we're talking about going outside. So one of the best episodes we had was Nick Walden, who is a serial entrepreneur, and he just very concisely talked about the importance of Google My Business and reviews, which every pediatrician should listen to. It's all about setting expectations and then putting a process in place so that you can succeed. And that's just a sales mentality. But, as doctors, you say sales and everybody says, oh my goodness, he just dipped into the trash can. And
that's right.
No, that's not true.
Pediatricians it's a dirty word, right?
Oh my God, he just got his hands dirty, take away his license. But the reality is everything in life is a sale. When we called you to do this podcast, we were selling you on the idea.
Yeah.
You're selling your services. When you go out on a date, you're trying to impress that lady that you're worth marrying for some reason. Right? Even if you have to use a couple of drinks, but there's just, you're trying to sell, right? But that's just life. And we shouldn't think of business, making money or selling as a dirty word. No one that I know, except the wife of Mark Zuckerberg, can be in pediatrics for the fun of it. The rest of us, it's the way we pay our mortgages.
Well, that's it. That's it. It's a service. And so, being a physician, if you're an independent physician, you are literally a healthcare provider wrapped in a business. And if you don't understand that business, that wrapping comes off fairly quickly. And then you're not able to actually provide your services. You're not able to provide your healing hands, right, to the children that need it. You'll have to go work for a hospital, and nobody wants to do that. Well, no, entrepreneurial people want to do that, right? So to your point, it is about understanding, that business. One quick sidebar about reviews. I have to say it. I give a talk about sort of, knowing how you look, to patients, and part of that is look yourself up, for example, in UnitedHealthcare's physician directory. There are reviews on there. And every time I reveal that, in a presentation, there's a gasp in the room where doctors like, what do you mean? There's reviews in a physician directory with an insurance company. I'm like, they're pulling those reviews in, from Health Grades and from some other platforms. And so you're rated right there. So if I get insurance and I go looking for a pediatrician in my neighborhood, I'm going for the 5-star review guy, versus, a 2-star review guy. And so if you're not actively managing your reviews, here's the other thing. Who's going to review you? The unhappy patient, unless you're actively asking for good reviews. So it's a simple thing at the checkout desk. You give them your business card and you say, was everything okay with you today, Mr. or Mrs. Smith? Great. Would you mind just scanning this little QR code and doing a quick review for us? Thanks so much. We appreciate it. So anytime you get a negative review, it's drowned out by 100 positive ones. But if you're never asking, the only reviews that are ever going to get posted are when somebody has a beef with you.
Or they're crazy.
Well, there's lots of that. Yes.
But okay, so yes, everything you said is what Nick says, and it's not. It's all about implementing the process. So the doctor's not doing it, the staff is doing it, and it's consistent. And the one thing he says that you didn't say was look for happy moments to ask for that review. So you don't really want to ask for that review after your 2-month visit when the kid's screaming and crying from all the shots they got.
That's right.
Or when Johnny has a fever 103, he just got diagnosed with influenza, and you got a meeting tomorrow, and you're like, I'm going to get sick, and my boss is coming in from wherever, China, and I can't miss that meeting. Oh my God, what am I going to do? No, you want to find happy moments to ask for that review and set that expectation that it's important. If we gave you 5-star service today, would you take the time to give us a Google review? Here's our QRS code. Give us 5 stars, because that really helps Dr. Bravo.
And the key here is giving them the code. If I've got to now search you online, figure out where your Google profile is, figure out where to put the review, I'm done already. I've already just wasted 5 minutes of my time that I would have done a review in. So you need that QR code, something really quick that they can just click right into, and that brings them right there to the review page, where they can just do 5 stars, love doc, he's great, fantastic, done. That's how you get,
Now, are you part of any mastermind classes, or do you have any personal coach that you meet with on a weekly basis on the business side?
I don't. And,
Okay.
Part of that too is, I wish I had the time, but often I'm the coach, right? But, I tend to tap into, just a lot of feel good positivity stuff. Anyway, that just is more spiritual, to me, that really, helps make my cork float, so to speak, right? And to me, if I'm bringing enthusiasm, to what I'm doing and excellence to what I'm doing, then we're doing it right. But an interesting question that you ask her, is there a particular mastermind class or coach that you would recommend?
Yeah, our mastermind and coaching groups. So when I have to giggle a little bit, because I haven't been able to get RBK Pediatrics Institute the QR code for the 5-star review, but it's set up, it's there, it's to be done, but I haven't been able to get it past George and Jim.
Get on that, George.
That's the problem. There's only one of George, but I'll have it done before Houston, just so Suzanne doesn't say to me,
there's a deadline. That's great. Nice pitch, Herb. You just
but it's true. I mean, we did it, and Greece Pediatrics is doing it. And so, but it was key. We created the QR code. It takes all 5 minutes.
That's right.
And we targeted the 2-week visit, because the mom and the dad are barely awake at that point. But they are awake. They're human.
But they're in a happy dreamy state.
As opposed to the 3rd-day visit, where the tsunami just hit you and you're like, oh, what? Where am I? What am I doing here? Who's this little thing? I really signed up for this. When do I get to sleep? But the 2-week, there's some more stability and happiness. And then the 18-year physical, because think about that. We've been together for 18 years. We have a young adult. We achieved our goal, both as parents and pediatricians. What a beautiful moment.
Right.
What a beautiful moment.
Yep.
So when you say you do a lot of startups, I do think it's important that they join a coaching group.
Yep.
And the reason the coaching group works is because you get lots of ideas, because I can't be good at everything. It's impossible.
Right.
Or I might know who to call. Like, don't waste your time with credentialing. Call Susan. It's the best couple of $1,000, whatever it is going to spend, because you're going to pull your hair out filling those forms.
Right. Absolutely.
And you're not going to do it right.
And that's the key, right? It's like, you leave it with the people that know how to do it and get it done right the first time. You don't. That's not the learning curve you want to be spending
No,
your money on.
cut the
The learning curve you
aggravation
want to
out.
spend your money on is improving your knowledge about business and how to run your.
Yes. And then the other big piece is, well, support. When you're having a really bad week and you're running a practice and you're one of 3 physicians or you're one of 1 physicians, you got no one to talk to about what terrible week you just had.
Yeah.
And just being able to, yeah, that happened to me. This is what, it'll get better. That's
Yeah.
all they need to hear. But the accountability piece. I need your fee schedule to go up because some insurance companies are paying you, you're charging $135. You're paying you $135 on that charge.
Right.
You
Well,
can't
isn't that
let
a
that
good thing?
slide.
No, it means they're leaving money on the table. If
You're
charging
leaving money on the
50,
table.
maybe they're going to pay you 142. Yeah.
They're not going to call you. They're not going to call you and say, oh, you know what, we pay 180 for this charge. You're being nice charging 135. Why don't you charge 160? We'll still pay it. They're not going to call you. So raise that.
Yeah.
And then the next week is, did you give your new fee schedule to your billing company or your biller? And is it instituted?
Yeah. Yep. It really
and that accountability
helps,
when you
yeah,
have
to have
so
that.
many things going on in your mind, patient care, staffing, family, taking the kid to the baseball game, getting together with your friends to go golfing for an afternoon, it gets lost.
Yeah.
And that's why people lose weight or get in shape when they hire a personal trainer. It's because they're paying, they got to show up at the gym a certain day and be there for 30 minutes. So anyhow, just that tidbit. But what do you think the future of independent practice is in America?
It is such a loaded question, again, because it's so highly dependent upon external forces, right? I mean, just, regulation alone, just complying with, with HIPAA and all of the things that small practices have to do. To me, the bright future of independent practice is bringing practices together, right? So being able to come under umbrellas like clinically integrated networks. So precisely to your point, or talking about, having a coaching group, having a group, to go to. When you join forces, when you come together in groups under, various umbrellas, and that doesn't mean you got to merge your practice in with somebody else's, right? It means that you're going to be better off when you have numbers behind you, right? When you have a group that is sizable, that's taking care of thousands of patients, that is sharing and collaborating around the data and the information on how to deliver care even better. That's going to be the future, because to continue to try and go it alone, in a 1 or 2 doc practice is a lot of really heavy lifting. I mean, if you're in a 1 doc practice, you're the one that's doing, vaccine inventory, stock takes, the most menial of tasks, at the highest paid resource of the practice. If you're seeing patients, you're bringing in the dollars. If you're counting widgets, if you're counting vaccines, you're not, right? And so being able to, make most effective use of technology, most effective use of effectiveness of scale and efficiencies of scale, meaning banding together with your colleagues under various umbrellas like clinically integrated networks, independent practice associations, accountable care organizations, or even just a think tank, right? A group think tank
MSOs.
to be able to share those things. And MSOs, of course.
Yes.
So,
if I can pay
you have to be
to
able to take advantage of everything.
if I can pay you a small amount of money to negotiate these contracts and get a better rate, that's one less thing I have to worry about.
Right.
And I get the discount, and I can go figure out, how do I set up an obesity program that's going to bring in more revenue and improve the care I'm giving in my office.
Right. But the caveat is always find the right partners there too, right? So, I've seen practices that sign up with MSOs, management service organizations, that actively manage their practice badly. And so you have physicians that say, well, I'm paying, this money to this MSO to take care of these things. Well, how well are they doing, right? The price point might be okay, but are you actually getting high value out of that transaction? And so, that's part of the reason why when we set up, IPMSO, it was specifically so that you could pick and mix the things that you need that will be done for you, as opposed to paying dollars to have somebody actively manage those things for you that may or may not work for you, right? It's always about engaging the physician and understanding how they're running their business and making active, well-educated choices and decisions about those pieces, in their practice but quickly and efficiently, right? So they can get back to the business of medicine. They can get back to actually practicing medicine and not spending all of their time, administering their practice.
Wonderful, wonderful. I could keep talking to you the rest of the day, but I'm
And
sure
we'll
you.
catch up again in Houston. That's
Yes, I'm sure you have to go take care of clients and make money.
I do. And you have patients to take care of too.
Yeah,
So
we got to lead with revenue, right?
we'll leave with revenue.
Lead with revenue. But thank you so much for sharing your time. As I always say in the podcast, giving your time is the most wonderful gift you can give another person.
Our talents, our treasures, and our time. Yep.
Yes.
So thank you for having me
so
on.
much.
All
Deeply appreciate it. See you in
Have
Houston.
a great day. See you in
Bye-bye now.
Houston. Bye-bye.
Bye.
They're not intended as medical advice, and the opinions expressed are solely those of the host and the guest.